Yes, it's time for another Puscast, a review of what was interesting for the last 2 weeks, at least interesting to me, in infectious diseases. There's snarky commentary, of course, and if you don't like it, you need to find another podcast. I ain't going to change for nobody, no how. This is brought to you by Pusware LLC, publisher of the Infectious Disease Compendium, a persiflager's guide, available on the web and as an iPhone app. As always, the world needs more Mark Crislip, and you can find my growing multimedia empire with all the links to my various and sundry projects at moremark.squarespace.com. Now, since this podcast, or Puscast, is CME accredited, if you take the online quiz and get a half an hour free CME, I have to tell you about my conflicts of interest. None, except for the vast sums I generate running my website. As always, the references are available on the interwebs at my website. And, as always, go to my website and download my applications, download my books, download my podcasts, download me. I've now been digitalized, and my prostate is fine, thank you very much. But I can be downloaded on the internet as well. Enough dumbass comments. Let's move on to the literature, shall we? There's this new way out for preventing infections. It's called hand hygiene. It was discovered by Semmelweis in 1860. It's taken a bit of time for that information to disseminate through the medical community. One of the programs we've had in my institutions is the It's Okay to Ask program, where we encourage patients to ask their physicians and other healthcare providers if they've washed their hands. I've always thought from the beginning that was a bankrupt idea, in that it's the same as having a sign, I think, on your airplane that says, ask the pilot if he put his wheels down before landing. I mean, really, we should do the basics without our patients having to nag us. But this study was an interview of patients asking them how they would react to a program of It's Okay to Ask. 57% were unlikely to question doctors about their hands. 43% thought that healthcare workers should know how to clean their hands, big duh there, and trusted them to do so. And 20% would not want their healthcare providers to think they were questioning their professional ability to do their job correctly. I once went around and asked patients if they would ask their providers to wash their hands, and they uniformly said no. Seriously, if you are resorting to an It's Okay to Ask program to increase hand hygiene compliance in your institution, I would argue that your program is already bankrupt. Currently, the Centers for Disease Control says that healthcare workers can return to work after flu when they are no longer febrile, or as some people say, febrile. This study looked at virus shedding in healthcare personnel in Seattle, Washington, and found that even when they were afebrile, 12 of 16 people shed virus by PCR, which was 75%, and 56% had virus detected by culture. So unfortunately, in healthcare workers and probably other people, fever is not a good marker for whether or not patients are shedding flu. As it says in the discussion, quote, because febrile and afebrile healthcare workers had similar virologic shedding durations and viral loads, the absence of influenza by real-time PCR or culture might be preferable to the absence of fever as a criterion for healthcare workers who are returning to work in settings where they place others at risk. A critical caveat is that a positive influenza, PCR, or rapid culture results do not necessarily indicate the patient is capable of transmitting virus to others, end quote. So, you get the flu, which you shouldn't because you got the damn vaccine, right? But let's say you're in the 20% where the vaccine is ineffective. When should you return to work? Certainly when you're afebrile in a couple days more. Though I can't imagine people feeling well enough, even after they break their fever, that they'd want to go back to work after a bout of influenza. For the record, I have no official recommendations as to how long healthcare workers should stay out. I follow the CDC guidelines, but perhaps patients who've had the flu when they come back to work, should be more compulsive about hand hygiene and mask wearing. But who knows? I think the Cochrane reviews have gotten dumber and dumber. I used to have all this respect for the Cochrane reviews, and then I started paying close attention to them as part of my science-based medicine writing, and my respect, especially like for their flu vaccine meta-analyses and their homeopathy meta-analyses, has led me to not have quite the respect for the Cochrane reviews that others may have. This one looked at vaccination for preventing postherpetic neuralgia. And their analysis has to be, what I think, one of the dumbest Cochrane reviews yet. Quote, did not find enough direct evidence to draw any conclusion about whether the vaccine is effective in preventing postherpetic neuralgia beyond its effect in reducing herpes zoster, end quote. Well, duh, it's called postherpetic neuralgia. So if you get the vaccine, it's going to prevent zoster, and therefore prevent post-zoster neuralgia. It's like saying seatbelts don't prevent people from going through the window of their car, in so much as wearing a seatbelt prevents you from being thrown through the car. But there's no data to support seatbelts not throwing you through the window of your car. I mean, the Cochrane reviews are really becoming bozos. And as long as we're on the topic of zoster, there was an interesting case report in Clinical Infectious Disease. There's this physician who's seropositive and had documented chickenpox at age 5. They go in to examine an immunocompetent patient who had zoster, and subsequently the physician developed acute chickenpox. So they were reinfected with varicella zoster, despite the fact they were immune, and despite the fact that zoster is not all that infectious, supposedly. So it's a cautionary tale. Even if you have a chickenpox scar, as I do, right where my third eye belongs, doesn't necessarily mean that you can't get reinfected with chickenpox, even in someone who has as non-infectious a manifestation as zoster. So, what's the cause of Guillain-Barré? Wasn't that a forward for, I think, the Warriors? Shot his free throws underhand. Guillain-Barré. Anyway, it's Guillain-Barré. What is the cause of Guillain-Barré? Well, one is Campylobacter jejuni infections, but this study looked at the incidence of GBS following primary cytomegalovirus infections in a prospective cohort. And they found indeed that the risk of developing Guillain-Barré after acute CMV is on par with that of Campylobacter. Quote, the incidence of CMV GBS was estimated to be between 0.6 and 2.2 cases per 1,000 cases of primary CMV infection versus 0.25 to 0.65 cases per 1,000 cases of Campylobacter jejuni. And I mentioned recently a study that showed zoster was associated with an increased risk of Guillain-Barré syndrome. Like my French accent? J'adore la langue française. So, wonder what the common pathway is of all three infections that leads to Guillain-Barré. But it doesn't appear, at least this year, to have been the H1N1 vaccine. Smallpox has been eradicated in the world, except, as I understand it, in the United States and Soviet bioweapons facilities. And the nice thing is that the average 7-Eleven in the United States has better security than Soviet old bioweapons facilities. Yay. Anyway, because there's still a potential for smallpox, and someone really could reconstruct it from scratch. If you know the genome of a virus, you can construct the organism from scratch. So in this modern era, no organism is truly eradicated. What they do, because of the risk, is some people are still vaccinated for smallpox, and they get vaccinia vaccines to prevent smallpox because of the cross-reaction. Well, somewhere in Maryland lies a martial arts studio, and 4 people in that martial arts studio came down with vaccinia. They never found the index case, although being in Maryland, near Washington, D.C., etc., maybe it was a military personnel or other person who got the vaccine, went to the martial arts studio, and then it was passed on to others in the studio. The presentation were pustules in one patient, vesicles on another, and curiously unknown presentation in two others, but all came down with the vaccine-associated vaccinia infections. Of course, people who get the vaccine are contagious, and it's presumed that it was spread by some fomite or sweat-dripped weight machines or who knows what in this institution. So when you see something that looks like smallpox, maybe it's actually vaccinia, and they got it secondarily because of the workout in the gym or other contact with a vaccinated person. One of the things I've learned over the year in infection control is it's never one thing that controls infections. Bacteria take advantage of any opportunity they can to infect our patients. So when you do multiple interventions, you're likely to get your best result. The VA had an initiative to prevent MRSA infections that was published in the New England Journal of Medicine. And in 2007, they implemented an MRSA bundle. That bundle included universal nasal surveillance for MRSA, contact precautions for patients colonized or infected with MRSA, doing good hand hygiene, good only after 160 years, and a, quote, change in institutional culture, whereby infection control would become the responsibility of everyone who had contact with patients, end quote. Duh. I mean, it still is embarrassing, I think, after all these years, that people don't take infection control seriously. And as a result, people get infected. But anyway, by doing all the above routinely in the VA system, they had a marked decrease in MRSA infections. How good? Well, 1.6 infections per 1,000 patient days with MRSA in 2007 to 0.62 per 1,000 patient days in June 2010 in the ICU. And in non-ICU infections fell from 0.47 per 1,000 patient days to 0.26 per 1,000 patient days. In my own healthcare system that I primarily work at, Legacy Health in Portland, we've essentially done the same thing in our hospital, and our infection rates have fallen across the board as well. We do not screen everybody who comes into the hospital for MRSA, just ICU patients. But even doing all the above that the VA does with a little less screening, we estimate in the last 2 years we prevented over 500 infections and decreased 200 deaths by having a universal and aggressive infection control and other safety initiatives in the hospital. So when you have some dickhead surgeon or dickhead internist or dickhead nurse, and they're all dickheads, who doesn't want to comply with infection control or other safety procedures because fundamentally they're ignorant dickheads, amongst other things, you can show them the New England Journal of Medicine article on the success at the VA. And otherwise, if they're still not compliant, well, you got a real problem with some dickheads in your hospital. I wonder, does dickhead mean I lose my iTunes rating? There was a time when all bacteria were susceptible to even the most narrow spectrum of antibiotics. It was a short time, and as I say, the Borg's phrase, resistance is inevitable, applies time and time again. And currently you cannot treat empirically. Down that way lies madness. One of the problems is that often cultures are negative. And this study looked at how good biopsies were for the diagnosis of hematogenous vertebral osteomyelitis. And they looked at whether or not prior antibiotics affected the cultures. The answer was no, it didn't. The other important aspect of the study was the utility of different types of biopsies. When they did an open biopsy, they had a success rate of 91%, whereas if they just did a CT-guided biopsy, it was 53%. So, unfortunately, if you really want to get a good yield for your vertebral osteo, you should probably do an open biopsy. 50-50 isn't all that great for committing someone to a 6-week course of antibiotics. Interestingly, about half the patients had positive blood cultures in this retrospective review. And if I had a patient with osteo and positive blood cultures, I don't think I'd proceed to biopsy. figuring that the blood culture was the organism that was in the spine. So it's interesting that despite positive blood cultures, they went ahead and biopsied the patients anyway. How long should you treat community-acquired pneumonia? As I've said numerous times, duration of therapy and antibiotics is determined by one of two factors: the number of fingers on both hands, therefore people get 10 days, or the number of days in the week, so people tend to get multiples of 7. If we had 5 fingers and 8-day weeks, we would have entirely different durations of antibiotics. Still, it's sort of a convenient number, lucky number 7. And this study looked at the treatment duration of severe community-acquired pneumonia. And they looked at outcomes in patients who had 7 days of therapy versus patients who had greater than 7 days of therapy. They excluded patients who died, were admitted to the ICU, who developed complicated pneumonia, who were not clinically stable, or who required long-term therapy because of some weird organism. So basically it was severe but uncomplicated community-acquired pneumonia, and found no difference in primary and secondary outcomes, whether or not they received 7 days of antibiotics or more than 7 days of antibiotics. The primary outcome was 30-day mortality. The secondary outcomes, by the way, were either the need for ventilator support or developing a complicated pneumonia within 30 days of treatment. So most patients with community-acquired pneumonia you can skate through with 7 days of therapy if they respond and have a uncomplicated course. I personally think that most patients are cured at discharge and that patients probably don't need to be treated with oral therapy at all. However, that will probably never be the standard of care, and I don't recommend it. I, of course, enjoy studies that confirm my pre-held biases. A good confirmation bias always makes my day better. This study looked at the utility of eosinophilia in travel-related schistosomiasis, strongyloidiasis, filariasis, and toxocariasis, and the relative risk of infection in patients who are traveling overseas for short periods of time. They found it unlikely for people to pick these diseases up on travel. I think the important thing is that, quote, testing for eosinophilia appeared to be of no value in routine screening of asymptomatic travelers for the 4 helminthic infections. They gave the positive predictive value of eosinophilia as a mere 15% for previous infections and 0% for recent infections. I think the take-home message is that, and I've always thought this to be the case, that you can't use eosinophilia as a good marker for whether or not patients have any number of parasitic infections, and this time is for strongyloides, schistosomiasis, filariasis, and toxocariasis. Hell, eosinophilia isn't even good for drug reactions. But if you really want to maximize your inefficient testing modalities, combine an eosinophilia with a C-reactive protein, and hey, then you'll really have nothing. Time for the hodgepodge, where I go through a bunch of studies without inhaling and without providing references. I'm half tempted to do the whole podcast without providing references. In this day and age, if you can't use the PubMeds and the Googles to find stuff, you're a pathetic excuse for a physician. Boy, I'm judgmental. So, they found 2 dead wild mountain gorillas in Rwanda, and they died of metapneumovirus. So it appears not only can we get infections from animals, but occasionally animals can be unlucky and get infections from us. And this may be the first case of human to gorilla transmission of a viral agent. So if you have a cough, stay away from gorillas. There was an article in Clinical Infectious Diseases that suggests an RNA virus that has hitherto been described as a cause of Kawasaki disease. Unfortunately, however, they have yet to exactly isolate the viral particle associated with this illness, but I think we'll probably find it in the next 5 years. An interesting study looked at the effect of the pandemic on influenza vaccination attitude, They looked to see if the big pandemic made those who were iffy about getting the vaccine more likely to get the vaccine. And in fact, they were. However, they remained willing to get the vaccine only for about a week. And then as all the anti-vaccine whack-a-loon stuff predominated in the media, the urge to get the vaccine fell. So if you have a cohort of people who are kind of hinky about getting the vaccine and you get another outbreak, the time to run around and vaccinate those people is in the first week after the brouhaha. You might have heard of Penicillium marfinii. Actually, it's Penicillium marnefii, and I'm not going to bother to go back and change that pronunciation. It's a mold fungus that causes widespread disease in Southeast Asia, predominantly in AIDS patients. Well, interestingly, the study looked at the epidemiology and seasonality of Penicillium marnefii and found that it was primarily a rainy season disease. Now, this may be due to the fact that it is probably spread by a rat. During the rainy season, both people and humans go indoors to escape the rain. I can speak for that here in Oregon. And then the organism is more likely to be spread to AIDS patients. I talked about an accelerated hepatitis B vaccination protocol in IV drug users a couple of podcasts ago that found it to be effective. They did the same one in HIV patients and found an accelerated schedule was just as good as a regular schedule in AIDS patients whose CD4 counts were greater than 500. The problem with the hepatitis B vaccine is it's most inconvenient to get. The usual schedule is at 0, 4, and 24 weeks. This, they did it at 0, 1, and 3 weeks and found a reasonable response in the HIV population. Follow-up for that 24-week vaccination is difficult in everybody, and it would be nice to have that a more universally used protocol. Patients with one strain of HPV are often co-infected with another strain of HPV. That other strain appears to occur randomly. But the good news is there's no sign that there's a synergistic increased risk in cancer, that each virus brings to the table its own risk of cervical cancer, and that you don't get synergistic cancer by having more than one strain of HPV. There's rabies in Michigan. Well, there's rabies everywhere. But the importance about this case is a man woke up at night with a bat on him, and he didn't seek care. 9 months later, he developed rabies and died of bat rabies. So, Bruce Wayne notwithstanding, if you happen to wake up with a bat biting you, you should probably hike your hiney into the ER and get therapy for rabies. There's a new inactivated vaccine for yellow fever that appears to be very effective. The current yellow fever vaccine is a live attenuated virus, and it unfortunately caused a very rare side effect, viscerotropic yellow fever, which can be fatal in about 2/3 of patients. There have been 59 cases reported in the United States since 1973, so it's distinctly rare, occurring with maybe 1 out of every 400,000 doses of the vaccine. The benefit of having a killed vaccine that's effective is you won't get active replication of the attenuated virus and kill you. And it appears that a 2-dose regimen of an inactivated yellow fever vaccine is every bit as efficacious in this New England Journal study as the live attenuated virus. Cat scratch disease is also seasonal. This study looked at cat scratch seasonality in France and found that it was most common in September through April, peaking in December. Probably when the weather gets bad, the cats come indoors and they give you Bartonella. The best remedy for this is to microwave your cat at the start of every fall. So is it better to randomly culture catheter tips, this is intravenous catheter tips, or only do it when patients are symptomatic? This study looked at this in a prospective randomized trial and found no benefit in routinely culturing catheter tips, and they suggested it only be done in patients who have bacteremia and fungemia. Often, however, you pull the catheter in a febrile patient who doesn't necessarily have positive blood cultures, and there is some studies to suggest that if the catheter tip grows Staph aureus in the absence of positive blood cultures, it's still a benefit to treat the patient, as they have a high risk of developing invasive staph infections in the near future. So this study didn't really look at the clinical scenario of febrile patients who have positive catheter tips but negative blood cultures and clinical outcomes. So it's not as clear-cut as the study would have you believe. Antibiotics being used for acne are not associated with resistant bacteria, which I suppose is good news. And a decrease in the acne will make the mirrors in your house a lot cleaner. The study only looked at Staph aureus and followed patients only for a couple of months, and looked at resistance to erythromycins and doxycycline. However, one would wonder if you followed the patients longer if you were more likely to find resistant Staph aureus in that population. There was a paper in the New England Journal of Medicine recently that demonstrated that cholera in Haiti occurred from a point source. This is another study that typed the Vibrio cholera in Haiti and showed minimal diversity consistent with a point source for the epidemic. So one person was kind enough to bring cholera to Haiti, and it spread from there. ARDS is a bad thing to have. We see it a lot, and patients go home. This study looked at patients in their 5 years after developing ARDS, and they all had exercise limitation, other physical and psychological sequelae, decreased quality of life, and sought health care more often. So if you get ARDS, you probably aren't going to bounce back to normal even after 5 years, which is a bummer. You're probably aware, if you're infectious diseases, that wound botulism is common in California. The heroin they use there is contaminated. I shouldn't say contaminated because that makes it sound like it's supposed to be organism-free. But it contains Clostridium botulinum, and they've been having ongoing cases of botulism in California. This is interesting and shows you how desperate heroin users are to get their fix, because they identified 17 people who had recurrent wound botulism from using their heroin. You'd think if you got a case of botulism once that you wouldn't go back to the habits that got you your disease, but evidently 17 patients needed to have their heroin and got wound botulism again. 3 people had 2 recurrences. Can you imagine having 3 episodes of botulism in your life? You really must need your fix. Should you give steroids in sepsis? I will defer that to your intensivist. This was a meta-analysis in the Annals of Intensive Care, and they suggest, after a review of the literature, that the answer is yes. I'll quote from the abstract: corticosteroids should be initiated only in patients with sepsis who require 0.5 micrograms per kg per minute or more of norepinephrine, and should be continued for 5 to 7 days, except in patients who don't respond after 2 days, and with a cortisol of more than 250 after an ACTH test. Hydrocortisone should be given at a daily dose of 200 milligrams and preferably combined with fluorocortisone at 50 milligrams. So, I don't know, steroids have been coming and going in sepsis since I was an intern, and I guess that might be considered a state-of-the-art review, but as again, I would defer to your hospitalist and your intensivist as to whether or not you should get steroids. Now, they always sell citronella at the stores to keep off mosquito bites. Does it work? This was a review of the effectiveness of citronella as a mosquito repellent, and the answer was, yeah, it does work for about 3 hours, but it's not as good as DEET, although it does smell better than DEET. And they suggest that adding vanillin to citronella oil products increases the duration of the effect. So I suppose if you ate lots of creamsicles, you'd have the same effect as citronella plus vanillin, but at least you know what product to look for if we ever get to summer and mosquito season. You'll be happy to know that the New Delhi beta-lactamase producing organisms are now found in the water supplies of New Delhi, which are used by local people for washing, drinking, and cooking. Now, the New Delhi beta-lactamase, as you're probably aware if you listen to this podcast, is a beta-lactamase found primarily in Klebsiellas and E. coli that make it resistant to every beta-lactams, including carbapenems, unlike ESBLs where you can still use imipenem, meropenem kind of drugs. Now that it's in the drinking water, it will probably spread even more rapidly across the world unless we can isolate the subcontinent of India, which to my mind seems unlikely. Cefazolin has a higher breakpoint now for susceptibility for the Enterobacteriaceae, such as E. coli and Klebsiella. The powers that be increased the MIC twofold to call it susceptible, but more importantly is done under the assumption that you're going to dose an adult 2 grams every 8 hours of cefazolin to treat your E. coli or Klebsiella. So if you have a Kleb or an E. coli that's susceptible to cefazolin, dose it at 2Q8, not 1Q8. In a case report of itraconazole causing quadriparesis and edema, they think that it was not due to Guillain-Barré in this study, but a direct toxic effect of the itraconazole, and it went away when they stopped the itraconazole. It's the only case of this reported to date. Goodness gracious, great balls of fire. We've reached the end of this Puscast. Lucky us. So now that you're done, go get a half an hour of free CME. Thank you, Legacy Health. And as if you're bored, go on iTunes and write me a glowing review. Yes, my voracious yet fragile ego requires you to write a review. Now, there is a growing Mark Crislip multimedia empire found over at moremark.squarespace.com. This is where I plug it. So you can just quit listening now if you don't want to listen to me blather on. But here's what you can find on my website. You can find these Puscasts. You can find my Quackcast, my award-winning review of supplements, complementary, and alternative medicine, i.e. scams. My Gobbet O Pus podcast, which is basically a redo of my infectious disease blog, which is currently over on medscape.com. I also write twice a month for Science-Based Medicine, and you can find links to Science-Based Medicine there. But wait, there's more. I have combined the first year's blog entries over at Rue Bordeaux or K-Lor Tumor into a book that you can buy on Amazon or on my website. It's called Pus Whisperer, A Year in the Life of an Infectious Disease Doctor. And finally, there is my iPhone, iPad, iTouch application, which allows you to get all the wisdom of the Infectious Disease Compendium, a Persiflager's Guide, to carry around in your back pocket. I mean, where do I find time to sleep, play golf, and eat? It's really quite remarkable. But anyway, all these things require reviews and purchase, so feel free to do all the above. Otherwise, we will end this particular Puscast. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you, in dictation, and I suppose goodbye.